Jodie Marquez is a physiotherapist with over 20 years of experience in neurological rehabilitation. It is this clinical background that drives her research to further our understanding of brain dysfunction and emerging rehabilitation techniques. This includes using EEG, MRI techniques to study physiological effects of therapeutic interventions. The main area of research focus to date has been electrical brain stimulation, particularly direct current stimulation called tDCS, and its potential applications in stroke rehabilitation. Other areas of interest include mood disorders and fatigue post-stroke, and adjunct therapies such as mirror therapy, exercise therapy, and hippotherapy. Jodie attained a graduate certificate in tertiary teaching in 2010 and teaches predominantly in the neurological courses of the Bachelor of Physiotherapy program, which is built on previous experience of teaching English as a second language for 5 years in a school in Mexico. She is the coordinator and lecturer for several physiotherapy courses and supervises numerous honours students each year and RHD students. Jodie will present her findings on her recent research into REGs. Please welcome Dr. Jodie Marquez.
Wow, full marks to you, Brenda, for pronouncing some of those words, and I'm sure you don't even know what they mean. And for your own research, because I don't know where you found some of those facts, but it was nice reminiscing with you. I come from a different perspective to both Melissa and Jason, in that I'm a researcher primarily. So I'm going to present to you some research that we've conducted on a different type of robotic device to the other two that we've heard about today. So I'm tasked with trying to provide some evidence to either support or refute the use of some of these emerging technologies as they evolve. So I am, have no objective in determining whether they do work or not. But if they do work, then I'm really driven to try and find out who they're going to be best applied to and who they should be offered to in a clinical setting. So that's where I come from. Even though I'm presenting this work today, and I need to probably turn that on. Even though I'm presenting this work today, the bulk of the research was done by my PhD student, Nicola Postel. So I just want to acknowledge her. She did all the data collection and the therapy intervention. And you'll see her in a lot of the slides that I show you today. I also want to acknowledge the Australian Institute of Neurorehabilitation. They're a not-for-profit organisation that were responsible for bringing this exoskeleton device to Australia, and it's the only Australian-owned device of this kind that we have. And also Newcastle Permanent Charitable Foundation, because they're the charity that actually purchased the device and provided it to us to use in our rehab research. And the device that we have is called a Rex Bionic exoskeleton, and we have affectionately named our device HELLEN, which stands for Hunter's Exoskeleton of Lower Limb Exercise and Neurorehabilitation. So we affectionately call her Helen. We believe that she's the only female exoskeleton in Australia, so we're quite proud of that. Here we go. Okay, so strokes tends to be a really common area of interest that we're applying robotics to, and the main reason for that is because mobility is one of the primary symptoms of stroke. And we know from Melissa and from Jason's presentations that if you want to regain the ability to move, then you need to exercise in upright postures. And so exoskeletons seem to fit that remit. We also know from Melissa's talk that you need to do lots of repetitions of exercise, and therapists get tired and robots don't. So they seem to be a good fit for that as well. And of course, you've also got those other secondary advantages of exercising in upright postures. We know that for all your organ health, so for your kidneys, your lungs, your gut function, your heart, if you can be upright for periods during the day, then you're going to reduce the risk of secondary complications from not being. So this is the Rex. Unlike Jason's device, which weighed, I think, 15 kilos, Helen weighs 53 kilos. It's a massive device. It's a bilateral exoskeleton, so some of them on the market are just single-limbed, but Helen is a bilateral device, and it has 10 actuators, so it is powered at the hips, the knees and the ankles with motors, one motor in each of the ankles, 2 in each of the knees and 2 in each of the hips. So it's a fully powered device, and the patient is strapped in at each of those joints, so hips, knees and ankles are strapped in. In addition to that, there's an abdominal binder and there's a pelvic harness, so the patient is really quite fully supported. We can easily adjust the leg length with an electric drill, so we can fit people in. Oh, I've learnt new skills. So we can adjust the leg length to suit someone as short as 4'7" to someone as tall as 6'3". So we have quite a lot of adjustment available in the leg length, but other than that, it is relatively rigid. And one of the issues that we had that with a lot of patients and with a lot of the general population, as we tend to get a bit older, we get a little bit more podgy around the middle, and there's very little give in the pelvic width of the device. So some people weren't eligible to use it because we couldn't actually get them in it because they're a little bit broad around the middle. There's been very few previous research studies conducted using the Rex exoskeleton. A couple of studies with patients who have multiple sclerosis and spinal cord injury, but they were largely looking at feasibility and whether it was safe and whether it could be used in a rehab setting. So we conducted a systematic review of all the available literature up until 2018, and since then there's been an enormous amount of literature published, but at that point there was nothing on the Exo and there was nothing on the Rex device, and very little on any other overground exoskeletons at that time. In fact, we could only pull the data from 5 studies, so this really is a rapidly emerging field of rehab. And I'm sure in the next couple of years when you come to conferences like this, there's going to be a whole range of new devices and evidence that you're going to be hearing about. But at the current point in time with regard to overground exoskeletons, the evidence is really limited, and in particular with independent research. So you can appreciate that a lot of the evidence comes from the companies that are producing the devices, so you need to be really careful of your interpretation of that evidence. So as I was saying, there's a lot of new devices being marketed at the moment. New ones are emerging all the time. So you need to think about what sets each exoskeleton apart. And with Rex, the one standout feature is that it's the only standalone exoskeleton that's currently on the market. So all of the other devices for overground exoskeletons will require you to use a walking frame or crutches or some external therapists for support, whereas Helen is completely freestanding. Once you're strapped in, you can go off and do your exercises independently without any requirement of using your arms. And that's a big draw card for people with stroke, because often, you have an arm that has very limited use, so it makes it difficult if you need to use a walking frame or crutches. So that's probably one of the standout features. The other standout feature is that most of the overground exoskeletons have a focus on regaining independent gait, and really that's not the way that the Rex is marketed. It's marketed as a tool to provide support for standing exercise therapy. So it's not designed to be used to facilitate gait, and I know Jason didn't mention it, but the Exo has been used by a patient to walk in a marathon in England, for example. Certainly could not do that in the Rex exoskeleton. It's too slow, too cumbersome. So it's not designed to facilitate you walking around independently, from room to room. It's designed for you to give you an upright posture so that you can perform upright exercises as part of your therapy. One of the biggest criticisms of the Rex has been that people say that because it's so supportive, is the patient actually doing anything in the device? Because you could just be moved around in it like a passenger on a plane. So we sought to investigate that as well. And because it is so supportive, I know that when I get in it, I feel a little bit frightened because I have very limited control over where my legs are going. So we wanted to know whether patients actually liked it as well. So let's meet Helen. Oh, what a shame there's no sound, because there's really nice ambient music that goes along with this. Oh, thank you, Mr. Music. Moves quite slowly. It's certainly not going to win any races, and that's probably one of the biggest limitations of the device. We want people to practice walking at their habitual gait speed, and you certainly can't do that with Helen, but that's not the intent of the design also. So we conducted a research trial. One of the main things that we wanted to look at was all of the other potential benefits that you might get from exercising in Helen other than just gait outcomes, because that's traditionally what's measured, but we know that there's lots of other potential benefits as well. And we also only wanted to look at people with severe mobility impairment, and that's a criticism of a lot of the earlier research. They researched people who can already independently mobilise, and I would argue that if you can already walk, why do you want a robot to help you do that? You should be practicing it on your own. So we wanted to only include people who either couldn't walk at all or needed heavy assistance to be able to mobilise. And we included people with stroke, with spinal cord injury, and with multiple sclerosis. We also didn't want to randomise people to a group where they didn't receive therapy with Helen, because we didn't think that was fair. So to overcome that, we randomised everyone into a wait list phase. So they came in, we conducted some baseline assessments, we sent them away to live their life for another 12 weeks before we got them in to start the therapy. And then once they started, they came into the university for 2 times a week for 12 weeks, for an hour each session, and we conducted therapy that was facilitated by Helen. And then we got them back 12 weeks later to see what their outcomes were. So to be eligible, you needed to be basically immobile, needed to have had your diagnosis at least 3 months prior to being recruited. And you also needed to be a resident of the Hunter, which was very difficult for us to enforce on occasions, but the main reason for that was because the funder was Newcastle Permanent Charitable Trust, and they donated the money as part of their community service agreement to provide services for residents in the Hunter. So that was largely outside of our control. The other thing was patients need to be discharged from inpatient facilities and services, but many of them were still receiving outpatient therapy or therapy in the home, and we encouraged that to continue. Our main exclusion criteria were related to the device, so if you didn't fit in the device, and as I was saying, a little bit chubby around the middle, that was often a precluding factor. But unlike Melissa's device, another big reason why people couldn't use HELLEN was if they had contractures in their calf muscles. So if you couldn't get your heels down in HELLEN, then we couldn't put you in it because HELLEN would force your heels down. So there was a risk of injury with that, either through tearing your calf muscles or breaking your bones. So we had to exclude people with contractures in their calf, which was another limiting factor. But for our stroke participants, potentially the biggest reason why people couldn't be in the trial was because of our cognitive assessment scale. So for two reasons, when you participate in a research trial, you need to consent to a trial, you need to show that you can understand what's involved and provide informed consent. And so we need to conduct a screen to show that you've got the mental capacity to do that. And secondly, when you're in a device as restrictive as HELLEN, we need to know that you can tell us if you feel uncomfortable, you feel pain, you want to get out of it, you feel frightened, all of that kind of stuff. So we use the standardised assessment, which is the Montreal Cognitive Assessment Scale with a standard cutoff of 19. And unfortunately, a lot of people with aphasia have trouble passing that test. So we really need to work more on how we can get people with aphasia to be more included in our trials, because that's really important to us in the future. So this is what we found. We recruited 22 participants, fairly wide age range. The average age was 54, but we had one participant who had a spinal cord injury and she was aged 25. A wide range of chronicity. So we had someone that had their stroke 6 months prior to enrolment, but we also had a lady who had been living with multiple sclerosis for 44 years. And then alongside our main trial, we also wanted to see whether exercise in HELLEN was passive, so we recruited 20 healthy volunteers as well, so that we could have a look at, well, what do healthy people do in HELLEN as compared to people with neurological injury, and we matched them for age and gender, so that'd be a good comparison group. So what did we find? We found that when you are in HELLEN, you are not passive, which is a pretty big, important finding in terms of using this as a rehab device. So we used oxygen consumption as a surrogate measure of energy expenditure or muscle activation, and we found that whether you are healthy or whether you had a neurological condition, when you do therapy in HELLEN, you are actively participating in that therapy and your oxygen consumption increases. We found that if you're healthy, you work harder than if you're not, and that's probably an indication of your disability. But we found also that with our stroke patients, when we reassessed them at the end of the intervention, that they were working harder than at the beginning of the intervention, and that may be an indicator of some improved fitness as a result of the therapy. In terms of the specific activities that made people work harder, we found that it was sit to stand practice and squatting practice where people worked hardest, and they didn't work so hard when they were doing sidestepping and lunging type activities. In terms of function, we found that there was some functional improvement in some of our measures of function, and that included bed mobility, sit to stand, and standing balance. And we also found that there were significant improvements in self-reported independence. So that's where you fill in the Bartell index, and I'm sure most of you have used that at some point in your rehab. So there were statistically significant improvements in some measures of function and in self-reported levels of independence. But what we can't really report on is those more physical measures because the results were so inconsistent. So definitely some people did improve their leg strength at the end of the trial. Some people did improve their lean body mass at the end of the trial and improve their balance. But those findings weren't consistent. So they weren't consistent across time points that we measured for individuals, and they weren't consistent between different participants. So we need to be really careful in our interpretation of those results. So even though some people did show improvements, others did not. And it's those inconsistent findings that we need to have a close look at in further research. And we also measured quality of life, which it really is the gold standard outcome for any intervention. If you as a therapist provide some kind of therapy and your patients say to you that the quality of their life has improved as a result of that therapy, you feel like your life is justified as a therapist. It's what you're aiming for. So if someone's, quads get stronger, not really important, but if their quality of life improves, then that really is meaningful to most people. There's a few different ways that we can assess that, and one indicator of quality of life is fatigue, and we showed that with our stroke population there were improvements in fatigue, and that really shouldn't be understated because a lot of stroke patients report that fatigue is their main symptom after stroke, and it's the most debilitating symptom after stroke. So if we can improve that, then we've achieved something. Unfortunately, we didn't have any consistent improvements in self-reported health status or in mood. So anxiety and depression remained relatively unchanged. Thank you. And then for all the participants that completed the trial, we got them to complete an anonymous survey at the end of it, so we got a better idea about what they felt about exercising in HELLEN. And overwhelmingly, the results were positive. There were a few negative comments, and those 3 comments I've listed there in green for you to see. But with regard to safety, likability, comfort, usability, all largely positive, and the overwhelming majority of patients reported that they would have liked to have continued to exercise using HELLEN at the end of the trial. And to get an even more comprehensive picture about the utility in clinical practice, we also did some interviews with therapists across Australia and New Zealand who have experience using the REX to ask their opinions about what they think about using the device. And that was a bit more of a mixed bag. And although therapists tended to report optimistically about the use of REX, they also commented that we've still got a bit of a way to go in terms of design changes. And that was largely around the time taken to fit people into the device and measure them up, the speed of the device. We want to have more different terrain options and things like that. So these are the key findings. We did have some positive results with fatigue and function, and knowing that exercise in HELLEN was not passive, but there was also some inconsistent findings with regard to those pure physical measures that requires some more investigation. And to end, I just really want to graciously thank all of the participants in the trial. Without people volunteering for research, we know nothing. And so everything that we know in science with regard to these devices is because of your participation, and I'd just like to thank you so much for that.